All right, so soft tissue injuries. This one's pretty straightforward, pretty simple stuff, but we'll still talk about it. Burns are the most important thing probably for us to cover when we talk about soft tissue injuries. So as you can imagine, this is something we're going to go on a lot more than maybe actually you would think. You guys have probably all gotten abrasions and all that stuff, and you don't call 911, you don't go to the hospital, right? Not a big deal. But little stuff that for us maybe not as big of a deal, maybe for somebody who's 90 is more of a concern, right? Especially as people get older, their skin gets kind of papery. I don't know if you guys have seen maybe your grandparents and their skin. So little injuries for us, or little scrapes and bumps for us that maybe aren't a big deal, can cause like big skin tears and bigger injuries for them. So we see this fairly common. Make sure that we're not overlooking the important things because of the visual things, right? I say all the time, you guys probably are super stoked on trauma right now because trauma's visual. It looks cool, right? You go on Instagram and follow like the EMS pages and it's be like cool pictures of trauma and gory stuff and all that. And it's easy to see, easy to look at, and easy to recognize what's going on. Medical is what I think is cool because I need to use my brain to figure out what's going on with medical, right? Like if somebody has a big avulsion on their arm, we wrap it up and we go to the hospital, and I don't need to think about it, right? So don't look at those cool injuries that are, you know, the social media injuries, and forget that maybe that patient's not breathing, or maybe there's something major going on because you're distracted by that, okay? So make sure that we're really looking at the patient as a whole and not getting trapped in the rabbit hole of these visual injuries that we're going to see, especially soft tissue injuries, not typically life-threatening. There's a couple different ways we can get these. There's blunt injury and penetrating injury. What's the difference between a blunt injury and a penetrating injury?
Blunt is more force, and then penetrating is like stabbing, shooting, or just puncturing.
So force versus, yeah. So yeah, you're right. You know, you're on the right track. Penetrating breaks the skin. Blunt force doesn't typically, okay? So, you know, you can have a gunshot wound with maybe like, I don't know, like bird shot from a shotgun from further away that's not gonna break the skin. That still would technically be a blunt injury even though it's a gunshot, right? So penetrating injuries break the skin barrier where blunt injuries don't. How about barotrauma? What's barotrauma?
Pressure?
Yeah, it's some sort of pressure thing, right? So that can cause some soft tissue injuries, and burns are obviously typically a thermal thing, could be a chemical thing, right? Something that breaks that skin barrier, it's going to be a burn. So are we going to see people dying directly because of these injuries? Probably not, right? It's typically something that goes on beyond that. And then a lot of these can be prevented by just simple things, right? You know, if you ride motorcycles, wear a jacket, pants, and boots and gloves, right? And you're gonna avoid these. A lot of the things that we do, or a lot of the reasons we see these type of injuries are very preventable. So hopefully people are doing the right things to prevent these, because it kind of sucks, right? It's not fun to have these things happen. So the skin is going to be that first line of defense for us, right? From the external forces, like if I were to do this to my hand along here, I'm fine because I have my skin to protect, because it was not enough force to injure me beyond that because of the skin. And also it's going to block infections, right? And remember, the skin is the biggest organ. It's an organ, it's a living thing, it's always changing, and it's there to protect us, do other things as well, keep us warm, but to really protect us. Obviously skin's pretty tough, but we can still get injuries to it, right? And all sorts of different things, from bruises to amputations. I'm sure you guys have all had some sort of soft tissue injury before, right? I'm sure you guys have all had bruises or abrasions. Maybe, I don't see any amputations, but you know, something along those lines. You guys know what this is all about. The first thing in trauma is we're always going to be looking at controlling bleeding, right? Because like we said, abrasion's probably not going to kill a person. Bleeding out could definitely kill a person, right? So we need to be make sure that we're looking at that. You guys probably know ABCs, right? You guys know XABC? Have you guys heard that before? Yeah, exsanguination or external bleeding, because exsanguination is kind of a hard word to say. External bleeding. Either way, whatever you want to remember, that's what we always want to be looking at first. So make sure we're controlling bleeding. And think beyond just what we're seeing visually, right? If there's this injury that I can see visually, what's going on behind that skin barrier that I can't see? What's going on in the bigger picture? And looking at bleeding and thinking about internal bleeding is important for us. Can we control internal bleeding? Not really, but we can recognize it and get them to the people that drive the fancy cars that can cut them open and fix them, right? So recognition is a big thing. We don't think about risk of infection too much in EMS when we really should. We should be better about thinking about that, right? Because we need to be patient advocates and we need to take care of our patients beyond just the one thing in front of us. And so a lot of that would be thinking about risk of infection down the line. What simple things can we do to help manage that? PPE for ourselves. How about for the patient? I mean, to an extent, we'll do some sort of wound cleaning, right? Like we can irrigate with saline. We don't carry a lot of that stuff on the ambulance. But yeah, we can irrigate, right? If you have a patient who, maybe you're out in the foothills, you have somebody who fell down, you know, an embankment and is all scraped up and they have twigs and dirt and everything, we could irrigate that out. What else can we do?
Sterile bandaging.
Yeah, bandaging. Sterile, we try sterile. Sterile, does that really happen in EMS? Is it really a sterile environment? No. Things are going to open. They'll be sterile, we'll open them, then they will no longer be sterile. But yeah, the best we can. Cover them up. You know, if you have abrasions, cover it up with a 4x4, some sort of bandaging, and keep it clean is the thing that we can do. And we're not as good about it always as we should be. But that's looking beyond where we're at to think about what's going to happen beyond when we drop them off at the hospital. So skin can vary in thickness. Very young, very old tend to be a lot thinner. Like I said earlier, you're going to go on a lot of elderly people especially that simple falls can have pretty massive skin injuries. I mean, skin tears will be essentially almost like flaps of skin that will just get torn loose and kind of pulled off. And so just keep that in mind when we're going on these calls and we're doing our assessment. Think about things like age and how that can affect the injuries we might be seeing. And then some thoughts or some spots are going to be thinner than others, like your eyelids, your lips, so on and so forth. So just something to think about with the skin when it comes to stuff like burns, those kind of things, right? You guys will see a lot of protocols will have like trauma criteria based off burns, and there will be differences for like burns to the extremities or full circumference burns because of the various skin thicknesses and that kind of thing. Skin has two major layers. The outer layer, what's that called? The epidermis, right? You guys probably, when you were kids, was that, I don't know, I'm probably a little bit older than most of you, but was that still a joke for you guys? Like, hey, your epidermis is showing, when you feel like real smarter than the other kids, right? So that's going to be that external layer, kind of dead skin cells. It's that protective layer. And then below that, we're going to have the dermis, okay? So epidermis, epi means what? Do you guys know what epi means, medical terminology? Above, around, kind of like that. So epidermis is going to be above the dermis there. It's going to be that tough protective layer. So you guys can see it here, that epidermis is that last outside layer, just kind of dead skin cells, right? And there's some pores and stuff through it. And then you're going to have the dermis as well. That's where most of the stuff is going to live. So you're going to have your vasculature in there. You're going to have your hair follicles, your oil glands, that kind of thing. And then some fat tissue as well. That's the yellow stuff. That's what it looks like in real life. I can tell you that for sure. It looks exactly like that in real life. And then below that, you're going to start to get to your subcutaneous, or sorry, that's going to be the subcutaneous tissue, and you're going to have like your muscle, whatever's underneath the skin there, okay? Yeah. So skin's going to cover all the external surfaces of the body, right? And then the openings are going to have mucous membranes. So what are our mucous membranes doing for us? Why are they there?
Protected from like infection.
Yeah, right? It's going to protect from infection. So if there's bacteria, viruses, whatever, that's what's there to protect us. So, I mean, that's what are boogers? Boogers are a mucous membrane catching dirt and other nasty stuff in the air so that it doesn't get back down into our lungs and get into our system, right? And we're going to have mucous membranes pretty much every opening to the world through our skin. We're going to have those mucous membranes. It's just to kind of help protect us and keep the bad stuff out. So skin does a lot of different functions. A barrier against infection, obviously, and then a sensory organ, right? So it has nerves in it. So my skin is telling me right now that I'm touching this, right? That's what skin's going to do. Helps us to regulate temperature, okay? Because obviously that's an important thing, right? Especially right now, you guys are probably as disappointed as I am that we've been waking up to almost freezing temperatures. Skin's going to help us to do that, right? It has that vasculature. It can constrict. It can dilate to allow different levels of blood to the skin to help us keep us warmer and cooler as needed. What else can the skin do to help regulate temperature?
Like sweat.
It can sweat, right? Yeah, that we can sweat to help to cool down temperatures as needed. So it can do a couple different things. And then maintain fluid balance as well, and that's going to be kind of the same thing. We can sweat, we can help to not sweat to maintain that fluid within our body. So the skin's, it's a pretty cool thing that can do a lot of different functions for us. So any break can allow bacteria to enter, and that can lead to infection, right? That's a pretty straightforward one. And that's the one that, again, like I said before, we don't think about as well as we should, right? We don't think, and you guys will see this in major traumas where you feel like you've got bigger, more important things, right? We're worried about the airway, we're worried about bleeding control, all of that, and maybe those little abrasions. You know, you get the motorcycle accident or the auto versus pedestrian that got dragged along the road, and we have those abrasions all over the place. And we're not thinking about those, but that we really should be, because maybe it's not going to kill them right now, right? But 2 weeks from now, if it's not covered up and they get bad infections, that could lead to sepsis and death. So we need to be thinking that as well. And then loss of temperature control can be a big thing when there's some issues to the skin. Where do you guys think that this is the biggest concern, the loss of temperature control with skin issues? Burns, 100%, yeah. So you guys will see when we talk about burns, it sounds counterintuitive, but keeping burn patients warm is really, really important. And you would think a burn patient, you would want to do like a moist dressing on them, right? Because they just got burned. But that's the last thing we want to do, because now they don't have that skin barrier. And we can cause pretty significant hypothermia if we get that patient wet. So burns can really affect the body's temperature control.
Still irritating burn though? Like with cool water a little bit?
It kind of depends. It depends on what it is. The first thing we want to do with burns is to stop the burning process. So if we have like a smaller thermal burn and we can irrigate it to cool it down to stop the burning process, we'll do something like that. But like a major burn, you typically won't want to, because it will affect their temperature control and can cause hypothermia. And then like chemical burns, depending on the chemical, you might have to irrigate it and all that stuff. So 3 different types, like we already talked about, of the soft tissue injuries: closed, open. Sorry, I guess we didn't talk about these already. Closed and open soft tissue injuries. So these are kind of some other words we used in disguise. Closed injuries are typically going to be what type of injury? Blunt or penetrating? Blunt force trauma is typically going to cause closed injuries. Open injuries are going to be what kind of trauma? Penetrating. Not always, right? You can get hit hard enough with a baseball bat to open the skin, but typically it's going to be penetrating. And then burns are just kind of burns. Any questions so far? No? All right, so the pathophys, as we talked about, cessation of bleeding is our primary concern, and that's going to take precedence over everything all the time. We're always going to be thinking about bleeding. You know, we have ABCs hammered into us. Now we're really trying to go for the XABC to make sure that we're thinking about that bleeding first. Then you're going to see some inflammation afterwards. You guys have probably been through this process yourself at some point when you've had some minor skin injuries, right? So you're going to go get that scrape, and then a couple days later, a couple hours later, it's going to start to be a little swollen. It's going to be red, maybe warmer to the touch as that healing process starts and gets a little inflamed. And then we're going to have a bunch of new cells move in to repair it, new blood vessels, and then some collagen to help stabilize that, right? Pretty simple stuff. As we start to have that new layer of cells and stuff, what are we going to start to build typically over soft tissue injuries? Like a scab, right? What is a scab?
A collection of white, or no, blood.
Generally, yeah, like a collection like white blood cells and just blood cells in general kind of clumping together. And that's going to help us build that, that protective layer back. It's going to help keep that wound nice and protected. So a contusion is going to be bleeding beneath the skin where the skin does not break. What's another word for this?
Oh, like a bruise.
A bruise, right? A contusion is just going to be a bruise. I'm sure you guys have all seen those before. A hematoma is going to be a collection of blood from that damaged tissue or in a body cavity. So they sound fairly similar. Hematoma is just kind of a bigger level of it, right? So a bruise, you know, like little kids, like when I was a kid, my legs were just covered in bruises all the time. I don't know if any of you guys were the same, just from playing outside and bumping stuff all the time. Little tiny bruises, nothing a big deal, right? A contusion, you might see big and swollen, kind of softer. That's a collection of blood underneath. And then crush injuries are going to be force directly applied to the body, typically over time, right? So getting hit with a baseball bat's not a crush injury, but that same amount of force being applied over a longer period of time can cause a crush injury. When we have that crush injury for 4+ hours, I mean, it could be, I feel like it can be shorter than this for some sort of like major crush injuries, but we can start to have the symptoms of crush injuries. So when something's crushed for a prolonged period of time, all those cells start to die, right? Because what do our cells need to continue to maintain homeostasis? Oxygen. What else? Glucose, right? Oxygen, glucose. It needs that stuff to work. So if those cells are being crushed and the vasculature to that tissue is being crushed, what are they not getting anymore? Oxygen, glucose, all the stuff it needs to live, right? So did you guys talk at all about cellular respiration when you guys did chapter 6, the human body? Yeah. So what is aerobic respiration? You guys remember that?
That's when you're like sitting, it's like rest and digest period.
No, that's the parasympathetic.
Oh, sorry.
So so you look like you know. What's aerobic respiration? You kind of nodded like you know.
It's oxygen in and CO2 out.
Yeah, essentially. So it is our body functioning in the presence of oxygen, right? It's all that process, energy being made in the process or in the presence of oxygen. So everybody right now is going through aerobic respiration. We're breathing, we have oxygen moving through our body, it goes to the cells. The cells break down glucose with oxygen there. When it breaks down, it creates what?
ATP.
ATP, thank you. Yeah, it creates ATP. And so in the presence of oxygen, that glucose breakdown is going to create ATP and it's going to create CO2. Okay, we're going to take that CO2, it's going to jump onto those red blood cells and we're going to exhale it out. It also creates water, which we're also going to exhale out. But it's going to create a bunch of ATP. It's like 32 to 36, I think, for a normal, healthy person. So when oxygen is not there, when those cells are trying to break down that glucose, trying to get energy without oxygen, then what happens?
Produce lactic acid.
Exactly. So we're going to produce ATP still, but only 2 ATP. We're also going to produce lactic acid. Okay, and so this was happening during crush injuries, right? If my arm's crushed under some farm equipment, is there circulation to those cells? No. And so they're going to be trying to create that energy, trying to stay alive without that oxygen. And so they're going to start to build up a bunch of lactic acid and all sorts of nasty stuff, as well as this cells just dying, which can be its own issue once that gets released. So that's crush injuries over time. They're getting starved and starved and starved, as well as having, you know, the vasculature broken, those little capillaries broken, all that from the crushing. And then at a certain point, if we release that crush injury, all that lactic acid buildup, all those dead cells, all that nasty stuff, then gets released systemically to the rest of our body and can cause major issues, right? All those dead cells can affect our kidneys, all our filtering and all that starts to get gummed up because we have all this nasty stuff. The lactic acid goes through and affects our pH balance, right? What's our normal pH levels?
7.4.
7.35 to 7.45. So 7.4 is just right there in the middle, right? 7.35 to 7.45. So we start to get all that lactic acid circulating. It causes some major issues systemically. And you guys all know what lactic acid is all about. You guys have probably all worked out to the point you got sore. That's just a minor amount of lactic acid. That's not a big deal. When it goes systemically, it's a bad thing. So there's not too much we can do for crush injuries, but it's something we need to be aware of. We can also get compartment syndrome, and so that's massive swelling that can occur. Essentially, it's like our skin is a balloon, right? And that balloon can only fill so much, right? And so that's going to be the compartment syndrome, that swelling that gets beyond what the tissues can really handle. Nothing we can do about that for us in the field, but you're going to go to the hospital and they're going to do, I can't remember the name of the procedure, but they'll like cut the skin to allow it to have a little more room to expand. But just something we need to be thinking about, especially in the presence of like crush injuries and that kind of thing. And also remember, we need to think beyond what we see, right? So if somebody was in a fight with somebody with brass knuckles and they took some hits to the abdomen, hits to the chest, they have some pretty bad hematomas or contusions on the chest and the abdomen. Do I need to be thinking that maybe there's more going on, right? What's behind that? What's beyond what I can see? What's beyond that skin barrier? Vital organs, what's going on there, right? That transfer of force. We always need to be thinking about that, right? You guys know the term mechanism of injury, right? We need to be smart. We need to be thinking, that mechanism, what was that? What can I see because of that? And what can go beyond what I can see because of that, right? So maybe there are some what look like pretty innocuous skin injuries with closed injuries that maybe some pretty major injuries below, right? Maybe there's a little bruising, they're complaining a little pain to the abdomen when really they have like a liver laceration that will kill them very quickly if we don't get them transported to the hospital in time. So make sure we're thinking beyond just what we can see. Right? And that's the fun part of this job, the investigation detective part of this job. Medical detectives is what's really fun. So open injuries, we're going to have a couple different types, abrasions, lacerations, avulsions, and penetrating wounds. So abrasion, slide's all messed up. Abrasion is pretty simple, just kind of that superficial layer of the skin, usually not a big deal. Can be a little more concerning if there's a lot of abrasions over larger periods, or over larger portions of the body. But in general, it's just kind of that epidermis, maybe the dermis being scraped. And so we see these a lot. You guys, I'm sure, have all had your abrasions at some point. Usually not too big of a concern. Lacerations is typically a smooth cut. And so this can happen from all sorts of different things. We can have lacerations essentially from blunt trauma if it's typically not over a larger surface area. You know, if we have something that's maybe a little thinner that's still technically blunt trauma, it can maybe cause a laceration. But typically these are going to be kind of a nice smooth cut. That's a pretty gnarly looking deep laceration. What do we really get concerned about when we see a big laceration like this? Are we concerned about that wound? Infection, but I mean, even like, are we concerned about the skin here, or are we concerned about something else?
The bone and
the bleeding, right? Yeah. Yeah, the bone, there's nothing we can do about it, but bleeding, we need to be thinking about the bleeding. And maybe, typically this will be pretty visual if you have it, that there will be pretty heavy bleeding, but we still need to be thinking about that and managing that. I think this is kind of a bad picture of an avulsion, but an avulsion is when there's going to be a layer of skin or the soft tissue that's kind of flapped and gets pulled off. You can see that it's essentially, there's a big chunk of the soft tissue missing from the leg here. Sometimes you'll have avulsions like this where that flap is just essentially removed, and you might have avulsions Like it's not too uncommon with scalp injuries to have like an avulsion to the scalp that can kind of like, you can flap it closed and it'll be open and closed. So that's, avulsion's gonna be kind of that flap. Again, we're worried about the normal stuff, bleeding, infection risks and all of that. And then an amputation, you guys are probably super excited, like amputation for the picture and then no picture. Come on, guys. An amputation is when any part of the body is completely severed. So it could be a fingertip all the way to an arm to all sorts of different things. You would be surprised, typically, amputations don't bleed quite as much as you would think, especially if it's like a cleaner amputation, just because our vasculature is kind of, rubbery is not the right word, but kind of like a rubber band, kind of snaps closed a little bit, right? What'd you say?
Elasticity.
Yeah, thank you. Yeah, kind of elastic. Yeah, so when you have that, that amputation, a lot of time it'll kind of snap closed. So it tends not to bleed as much as you would think, but there is still the risk of exsanguination from amputation, so make sure you're thinking about that. And obviously the bigger, I'm a lot less concerned about a finger amputation than I am about a leg amputation, right, as far as the severity of it. Penetrating wounds, we've talked about quite a bit already. So open wounds, shooting and stabbings are gonna be the big one that we need to be concerned about for penetrating injuries. Even in, you know, quiet, safe Boise, we still see these from time to time. Not as much as if you were in, I don't know, I think Birmingham is typically the highest violent crime rate in the US, right? Or at least it has been for a while. Where?
Baltimore also has that.
Baltimore, yeah. So, you know, if you guys worked EMS there, it would be a whole different thing. There's a Netflix show, at least I don't know if it's still around, called Flint Town. If you guys, it's a documentary that follows first responders in Flint, Michigan. Flint, Michigan is mostly famous for the water issues, right, if you guys remember that. But it's also super high crime rate. So it follows like some cops and some EMS responders, and they're just on shootings and stabbings all the time. Where here, I mean, I've been on a number of shootings and stabbings in Boise, just not a ton of them. We don't see it very much. But we still need to be thinking about it. One of the big things we need to do for penetrating injuries is to get that patient naked so we can look for all the wounds, right? Depending on the caliber, depending on how far a gunshot wound was from, all those things, we could just have like a simple through and through, or we could have where a bullet comes in, hits the spine or something hard, and then deflects. So you could have a wound here and here from the same gunshot. It's totally plausible for that to happen. And so I can promise you, if you come in to the ER, if you come into the trauma bay with a patient with penetrating trauma and they are not naked, you are going to get ripped apart by the trauma surgeon and everybody, because you very well could have missed something. So make sure that you guys are taking the time to identify all that. I would say regardless of how that patient was given to you, there was one shift I was on years ago. I'm at St. Luke's downtown, so you guys probably know St. Al's locally is a trauma center, right? That's where all the penetrating trauma typically goes. I'm at St. Luke's downtown. We just dropped off a patient, and I hear on the radio that there was multiple stabbing call going out at the Spearmint Rhino downtown, one of the strip clubs. And yeah, I've always been curious what happened, but it's probably exactly what you'd expect. You know, we're hearing the radio traffic as we're like getting our gurney ready, and we hear that one of the guys just like left the scene. One of the stabbing victims just left the scene. So we were thinking like, well, maybe they're going to come here. If they come here, they're going to have to go to St. Al's because St. Luke's can't handle it, right? They just don't. It's just not what they do. So we kind of were hanging out, moving a little slower than normal, just because we knew if we left, firstly, we'd probably just get called right back, and secondly, if they called somebody else, it would take a while. So we're hanging out, and we see the guy just walk through the doors. He's holding like shirts over himself as he's walking into the bay with multiple stab wounds. But so they get him in, they stabilize him, whatever, and he's all packaged up right, and keeping trauma patients warm is really important. You guys would probably know that's what we do for trauma shock patients, right? Keeping them warm, really important. And so The guy's laying there. When we go to transport him to St. Alice, he's laying there. He's covered in blankets, all comfy and cozy, looking nice. And so I'm like, cool. He's got multiple IVs going. Doctor's already started these things. An ER physician, multiple ER physicians have already done their assessment and treatment on this guy. I'm just going to leave him warm. I don't want him to lose any body heat in the back of my ambulance because it's cold outside. We'll keep him warm. We'll take him to the hospital over at St. Alice. Arrive at St. Alice, get there. Trauma surgeon, first thing he does, pull off the blankets to look at the wounds. And he has multiple stab wounds to the thorax with no occlusive dressings on them. You guys know occlusive dressings? Have you guys talked about that before? Maybe not because you guys aren't at chest injuries, I don't think yet. But yeah, it's a non-permeable dressing. So it's to help to stop patients from having like a pneumothorax. If we have penetrating trauma to the chest, we can pull air in through that penetrating trauma into the chest cavity and cause a big air bubble essentially in the chest cavity. So it's usually just like a plastic film we put over that to block that air transfer. He didn't have any of those on like 3 stab wounds in the chest, right? So thankfully he didn't get a pneumothorax, but I can tell you the St. Alice staff was not very pleased with me that I didn't just take the time to visualize those wounds. So in all cases, when it's your patient, take the time, visualize everything, look at those wounds, make sure we're not missing anything. You want to count the number of penetrating injuries if possible. I would never chart entrance wounds and exit wounds because I don't know. Typically, they do look a little bit different, especially more like high caliber. They might look a little bit different, but we don't know, right? We didn't see the wounds be made. We don't know which one's the entrance. So again, I have known paramedics that got a strict talking to from trauma surgeons because they said they had a entrance wound here and an exit wound here, and they're like, you don't know that. Doesn't matter? No. But it is what it is. So charting wise, because you guys can probably imagine, you might be going to court on a shooting patient, right? That's probably a higher prevalence of going to court on these kind of patients. So I would just always put penetrating trauma found here, penetrating trauma found here, and not identify entrance or exits. And then determining the type of gun, if possible, is always good, okay? There's a big difference between some high caliber rifle and like a smaller caliber handgun or something like that. So if we can find that out, that's going to help paint a picture for the trauma team at the hospital to have a better idea of what they expect for internal injuries. Blast injuries, there's a couple different phases of the blast injury. So the primary blast injury is going to be that blast wave. Have you guys ever seen video, like slow-mo video of like the blast wave, right? Like Mythbusters, you'll see that cool blast wave go out. So that's going to be that primary injury. And so that's going to be a pressure wave, and that can cause that barotrauma we were talking about, right? That pressure change. That can cause some if you're close, some pretty significant injuries, especially to internal organs and stuff. So that first primary blast is going to be that pressure wave. Second is going to be all of the debris that comes after it. Because again, if you guys have seen videos like that, pressure wave, poof, and then it's going to cause, I think it essentially causes a vacuum behind it that pulls everything out. And so all of that's going to come afterwards and hit the patient. And then the tertiary blast injuries, after I get hit by things, I'm going to go flying as well, and I'm going to hit other things. So that's going to be that third phase of a blast injury, okay? We're not going to talk a lot about blast injuries, but make sure you guys know these phases. That's not an uncommon thing to have to answer questions about when you guys go to take your national registry exam. Sometimes you'll see these questions. Thankfully, we don't see blast injuries very commonly, at least not in just your standard EMS kind of situations. Everybody doing okay? Good? Any questions? No? Cool. I try to go like 45 minutes at most before a break, so we'll take a break here soon. So assessing open and closed injuries. Which one do we think is easier to find and assess, open or closed? Open. Typically open, right? Because again, it's visual, it's easy to see. So typically easier to find, but we still need to really do our good assessment for those closed injuries. So open injuries, typically we can identify with our eyes. What other things might we need to do to assess closed injuries?
Identify if there's any like large swellings in an area.
Okay, what's one way we could do that beyond looking at it? Palpation, right? We need to palpate. And you guys have you gone over your trauma sheet yet? Like, have you gone over the head to toe? Not yet? No. I thought it said trauma on the schedule today. So yeah, you guys are gonna learn, we're gonna get hands-on. We wanna touch everything. When we're doing a trauma assessment, we need to feel for crepitus. What's crepitus?
The bone.
Bone on bone, right? Those broken bones rubbing against each other.
Actually, speaking of like palpitation and stuff, with like gunshot wounds and stuff, do you guys do like the tiger claw where you like just feel the entire body? Do you know what that is or no?
I don't know the term, but we'll do that pretty much anyways, yeah.
It's like you like tiger claw and your finger will like pop into like the bullet wound.
Oh, no.
Feel the body.
No, I've never heard of that before. Yeah, it makes sense. So just to kind of catch anything that you're not seeing. Yeah. No, it's not something that we're taught, but we're still going to get hands-on, right? You guys, when we're doing trauma, we're going to expect you guys to, when it's the chest, to touch the chest, top to bottom, get your hands on everything. Same thing in the abdomen, feel the abdomen. So I see what you're saying. So you kind of pull down to catch anything.
Yeah, like you go across like the entire body once you have like the shirt off, you
Mhm.
the entire claw, the entire chest all the way down.
Mhm.
You kind of like look for blood as you know, as you're doing it.
Mhm.
If you have a bullet hole, your finger will like pop
Snag
in
it a little
there,
bit.
that's when you know where to, like,
Yeah.
close it up and stuff.
Yeah, we do kind of the same thing, just a different method to get there. But I like it. It's a good idea. I'm assuming that's a military thing?
Yeah.
Yeah. Yeah, we do things fairly similarly. Military is just really good at a couple things. And like
Yeah.
gunshot wounds, military, really good at. But yeah, you guys will just get in the habit of you should be getting your hands on everything, right? You should be touching everything, visualizing everything. And that's also something that we really teach, especially like up in the scalp. Run your hands all over and then look at your hands. Because like me, if I'm bleeding from my scalp, it's gonna be really easy to recognize because I don't really have any hair. But if she has a scalp, like bleeding from her scalp, she has dark colored hair and a lot of hair, you may not see that. So you need to get your hands in there and then look at your hands to see if you see any blood on your gloves. So kind of a similar idea. So whenever we hear about some pain somewhere, we see a deformity, bruising, swelling, all that stuff, we need to assume there's the possibility of some sort of closed injury. I don't know if Wade really goes through this part of it slide by slide. I'm going to kind of jump through it because most of it is just repeated over and over. When we're talking about these, though, MOI, the mechanism of injury, is really important. Did Wade show you guys there's like a YouTube video, the mechanism of injury video? I'll have to pull it up for you guys. It's pretty good. But we really need to be thinking about that. Where does our thought process about the MOI start? Like, what stage of the call are we starting to think about the MOI?
Before you're even on scene.
Yeah, before we're even on scene, right? You know, if we have dispatch information that says that somebody fell from an 8th story window, we need to be thinking already about what resources we might need and what kind of injuries we might see based off of that mechanism. So the MOI, thinking about that, that's going to start really early before we even get to the call based off dispatch information. And then when we get there, we're going to start to do that visual assessment to think about the MOI. Because, and you know, 8-story fall from an 8-story fall into or onto concrete versus into, I don't know, like what's the, like in a movie, right? There's like a trash bin full of old paper, right, that they would fall off, whatever. Some sort of soft landing, those are different. We need to visualize that when we get there to think about what that means. So always thinking about that, and then the MOI can also lead you to be thinking about possible threats, safety issues for yourself as well, right? So if we get gunshot wounds, we get stabbings, we get violent crime, we need to be thinking about ourselves and continue to think about that. So a buddy of mine, he worked out in Oklahoma City for a while, another pretty rough area for the most part. And he told a story about going on a gunshot wound patient, and it was like a gang-related thing. Gunshot wound patient, they get there, they're treating this guy, he's pretty bad shape, multiple gunshots lying on the floor. And somebody just walks up onto the scene and they're like, hey, what are you doing? You know, like we're taking care of this. It happened to be the gang member that shot him initially, walked up and just shot him multiple times again. With them right there working him, the guy just walked up and shot him again and then walked away, right? So scene safety, MOI, all that, that's a continual thought we have. We're never just like done with scene safety and thinking about these things. Always be thinking about that and the possibility of what can happen.
So with that story, did the cops clear the scene already?
I don't know what the cop situation was. And we also, if you guys work around here, like we go on somebody that, I don't know, there was a pocket knife report on scene, you're gonna have 19 different cops show up. That's not the case everywhere. So there could have just been one cop on the scene that was doing what he could, you know, talking to people over here, and then this guy comes around here, and you know, so just always keep your head on a swivel with it. So, and then also, like I said, think about additional resources based off of the MOI. So, you know, it's wintertime, and you get a call for an accident, bogus Basin Road, right? That could just be a little fender bender, or what else could have happened in that situation? Somebody slid off and went down the hill. Are we going to be enough, or our normal response going to be enough? No, we're going to need tech rescue. We're going to need all sorts of stuff. So I'll be thinking about that based off the MOI as well. Or even just a simple one, just like getting a helicopter in the air to come and pick up a patient if we're going to be far away. Something we need to think about.
Someone just peeked their head in.
It's probably a CPR student. So yeah, and in general, when we talk about additional resources, it's a lot easier to request those early based off of the MOI, get on scene and be like, no, we can handle this. We don't need that helicopter. We don't need whatever. Than to not think about it, get on scene and be like, I need this resource here, and now I need to wait an additional 20 minutes while the patient's bleeding or whatever, or down an embankment that we can't get to them because we didn't call that right away. So know your local protocols, obviously, as far as whose responsibility it is to call. Typically, like Ada County paramedics, the field crews will typically not call for a helicopter. They'll report to the supervisor, say, hey, I think we should get a helicopter en route, and they'll get that going. So know your protocols and how those things work, but be thinking about it early, and it's not bad to get those started early, and then just stand them down if we don't need them. Primary assessment's pretty straightforward. Do your thing. Circulation, obviously, this is what we're really going to be thinking about in the presence of trauma typically, so make sure we're managing that bleeding, and then assess and treat for shock. Treating for shock, again, I don't know if we've talked about it with you guys specifically, but oxygen, keep them flat, keep them warm, right? You guys have heard that before. Make sure you guys are really thinking about that and doing that. There's not a lot that you guys can do for these patients, right? There's not a lot that I can do, really. I mean, I can fill the tank a little bit more with some fluids, maybe give them some vasopressors, but for the most part, EMS systems don't carry blood. They can't do surgery. They can't do that kind of stuff, right? So EMS, we're a Band-Aid. EMTs, medics, we're a Band-Aid, right? The people that can actually fix our patients are at the hospital. So our role is to kind of get there, recognize, and transport as quickly as possible. That is the bread and butter of a good EMT if you guys are working just as an EMT, is having that recognition, having that suspicion that maybe what you see is not the whole story. Maybe there's internal injuries or something beyond that we need to get managed, and getting them where they need to go quickly so that they can be treated in the way that they need to quickly. Okay, so really knowing this stuff is important for you guys. Airway and breathing, straightforward. Manage it if you need to. Transport decision, I'm sure you guys have already recognized, like you need to take critical patients quickly, like load and go. You guys have probably heard that term already, versus stay and play. Decap BTLS, do you guys know that one yet? What is it? Deformities. Contusions. Abrasions. Penetrations. Burns. What's the T? No. I mean, we're already at that point if we're doing decap BTLS. It's not really trauma. It's going to be tenderness. Tenderness, what's the L? Laceration, and S? Swelling. Good, yeah. So you guys will see there's a whole lot of mnemonics that we use in EMS. And the main reason we do that is because this is really easy when you're tired and unsure to fall back on, right? knowing these, having these down really well, when it's 3 o'clock in the morning, you haven't slept for 20 hours, you're on your 12th call of the day, and you have this trauma patient in front of you, it's really good to have those to kind of like, okay, what could I be missing? Okay, decap BTLS. I'm going to run through, think about all those things, and look as I go head to toe.
Just a reminder, what is OPQRST?
You guys need to watch our rap video on our YouTube. We'll stick it in your head. I'm not kidding. We have a video on YouTube for it. Onset, provocation, quality, radiation, severity, time is going to be OPQRST.
And that's
No, you guys aren't paying me enough for that. I get paid for my time. No, but we really did. It was actually really fun. But yeah, so sample, do you guys know sample? What's sample?
symptoms,
Signs and symptoms,
allergies,
medications,
pertinent
pertinent past history, whatever, however you want to say that one.
Last oral eaten and events.
Last oral intake and events leading up, yeah. So those are all going to be used. Sample is going to be used really every single call. You should be thinking about sample histories. OPQRST, we like to talk about this in for all the medical patients. OPQRST is really for pain specifically though, right? If you're asking a shortness of breath patient, if their shortness of breath radiates anywhere, it doesn't really fit. So it's really good for pain though. So if you have a patient who's complaining of pain, OPQRST is money. So chest pain especially. And then decap BTLS is going to be what we use to find injuries. Okay, so head to toe. If I am proctoring you guys for your trauma assessment, I'm going to expect when you go to do your secondary assessment that you're going to tell me, I'm looking for decap BTLS. If you tell me you're going to be using one of these mnemonics, I'm going to ask you, that's great, what does that mean? So make sure you guys know that mnemonic so you can spit it back out to us. As you guys already know, if you can't get this information from the patient, look for a bystander, a family member, somebody that maybe we can get this information, right? You guys are all young. You all know smartphones pretty well, probably. You might even have your own health information already stored on your phone. We can look for phones, look to see if that information is stored there. Just try to find it the way you can. Secondary assessment, we'll go down that later. Just make sure that you're really doing a good head to toe. Make sure we're listening to breath sounds, especially patients with closed trauma or blunt trauma to the chest. We really need to be thinking about that. Listening for those in case there's pneumothorax that we sometimes overlook. If there's a gunshot wound, everyone's going to listen to lung sounds. It's straightforward. But don't overlook it when we have closed trauma. Look for that asymmetric chest wall movement, especially again with closed trauma patients. What's that going to mean, the asymmetric chest wall movement?
One of the lungs has damage to it, like collapse.
Possibly, yeah. So it could be like a pneumothorax. So what are we going to see in the presence of a pneumothorax as far as chest wall movement?
One
non-bilateral.
Yeah, one not really moving as well as the other. What if I'm doing this as I'm breathing? What does that mean to you guys? If one spot of my chest is going separately from the rest of my chest.
that is descendant, or that's
You guys know the term flail segment? Have you guys heard that term? No? So a flail segment is when we have 3 or more ribs broken in multiple spots. So our rib cage is kind of like a wall right now, right? If we have 3 or more ribs that are broken here and here, that whole piece of that wall is now loose. It's not connected to the rest of the wall. And so as we breathe, you might see that asymmetric movement where instead of that, the chest going out as we breathe, that will come in a little bit. Okay, so we might see that that flail segment moving independently of the rest of the chest wall. So that's another thing for us to look for.
You're saying
Flail. Flail segment. Yeah, F-L-A-I-L segment. They're not super common, but it's something we need to be thinking about. There's nothing we can do. The old school books will tell you to do create a temporary chest wall by putting a lot of bulky dressings around it, but they've found nothing really fixes a flail segment. All we can really do is doing positive pressure ventilation for flail segments. Does that make, let's back up a little bit. Positive pressure for flail segments. Does that make sense to you guys? Maybe? No, probably not. You guys haven't done chest injuries yet, so I don't know how well you know all this stuff. But how do we breathe? How do we breathe air, bring air into our body?
We have a negative pressure environment in our lungs. Where
Sorry, say it again a little louder.
I believe we have a negative pressure in our lungs, so it like allows us to input air into our lungs.
Yeah, exactly. So how do we create that negative pressure? One step back a little bit.
Vacuum.
What happens to create that vacuum? Our diaphragm goes down, right? Our intercostal muscles go out, so our chest cavity becomes larger. As it becomes larger, it's like opening up a bellows. It's going to suck air in. We're going to suck that air in through our airways. We should be sucking through our airways, right? If we have penetrating trauma to the chest, we'll maybe suck in through that opening, but that's a different chapter. So that's what's going to happen, right? We create a vacuum inside of our chest, and so we pull air in. And that happens by expanding our chest and making it bigger. If I have a piece of my chest wall that's loose, it's not connected to the rest of the ribs, as that vacuum starts, instead of that going out with the intercostal muscles and the rest, it's going to kind of get sucked in the vacuum a little bit. So it's not going to open like the rest of our rib cages. It's going to get pulled down. And so we'll see this go while this comes kind of down and in. Okay. I'll see there's a good video. I don't love looking at the video because it's definitely a kid with like the asymmetric chest wall movement, but I can see if I can find that flail segment video for you guys so you guys can see it. Assessing the neuro system. How are we going to assess the neuro system in a trauma patient? Yes and no. That's assessing the head. Yeah. So I mean that's still the brain, right? How are we going to check nerves down here?
Oh, with like.
What'd your mom and dad always do if you thought you broke your finger? Can you wiggle it? Right? That's what we're going to do. Can you wiggle it? Can you feel it? So just checking CMS, that's the easiest way to do a neuro check. That's more like a spinal thing, right, to see if there's any break in the neuro system from the brain down to the extremities. We're going to have them just wiggle, see if they can feel us. Vital signs wise, if we're thinking blunt trauma, maybe some internal injuries, we need to be really, really good about looking at stuff like tachycardia, right? What's one of our first signs of a patient who's in the stage of shock? Tachycardia, right? Because that's a compensated shock. Hopefully you guys really, really, really have taken the time to understand shock and compensated versus decompensated shock. But I know when I went through EMT school, my understanding of shock was like blood pressure's low, they're in shock, and that was it. That was my baseline of understanding. And somebody who already has a low blood pressure has gone through so many steps to get to that point that they are in decompensated shock. By definition, if their blood pressure is low, they are no longer compensating. We are way behind if that's where we're recognizing shock. We need to be looking to see tachycardia. We need to be looking to see that anxiety that they tend to feel. It's a very common thing. They feel anxious. The tachypnea, maybe they're breathing a little faster because they need that extra oxygen in, right? So we need to be looking at these things and recognizing in the presence of an injury, especially like an injury to the core of the body, I'm seeing that unexplainable tachycardia. Obviously, if you went on a patient like you're doing a standby at a sporting event and the patient falls down while they were doing a run or something, right? Or a football game, somebody just got hit really hard after they ran 50 yards down the field and their heart rate's a little high. That makes sense, right? I'm not super concerned about that unless it doesn't start to come down. But you just have grandma fell down the stairs and there's no reason to think her heart rate should be at 130 and it's at 130. That needs to be something that you're really thinking about, right? It's probably a sign of early shock. And then skin signs. One of my favorite EMS sayings is skin signs are like Shakira's hips because they don't lie. So really make sure you guys are thinking about skin signs, okay? Let's take 10 minutes and then we will come on back. All right, so this is not the video, which I'm okay with because like I said, the other one was a kid and I just don't like looking at injured kids, but this will be a good representation of what this looks like for you guys. So if you watch, this side of the chest goes out right here goes in. So it's that paradoxical movement. Yeah, so I'm assuming somewhere around here probably he has a flail segment, so that portion of the rib cage is just floating, and it kind of comes down when this part goes out. So just something obviously pretty visually striking, at least this one, right? But something for you guys to make sure you're looking at if you go on a patient with chest injuries. All right, I think everyone's back, right? All right, let me make sure this is running. Check, good, cool. Cool. All right, I'm gonna try to work a little faster because we're already like an hour in and we're like not even done with one of the three. So I talk too much. We'll try to be a little quicker. Reassessment, make sure when we reassess, just in general, what are we reassessing?
Airway, breathing change.
So like our ABCs, right? Like reassessment, we should essentially be doing another primary assessment on them, survey, look at the ABCs real quick, reassess vital signs, and then also reassess our treatments. Anytime we do a treatment and we do a reassessment, we need to reassess to see, is it helping, is it hurting, or is it not changing anything, and we need to think about something else, right? So make sure that you're doing that every time you have a patient that you need to reassess. Not much we can do for most of the closed tissue injuries. There's the Rice's mnemonic. I feel like this is kind of controversial at this point. Not everybody agrees with the Rice's. No, yeah, write it down. It's still in the book. But I feel like there's a lot of people that think the ice is not good for injuries. But this is still kind of what's taught is Rice's. So rest, ice compression, elevation, and splinting is what we want to do. Just know you guys might get somewhere here or read something that disputes, most specifically, ice treatment in the presence of some sort of soft tissue injuries.
Why do you think ice doesn't work?
I think the thought is mostly it causes more tissue damage from the ice than not using the ice, because ice is supposed to vasoconstrict, stop kind of the blood to the area to help it not to swell. And I think that it's just, maybe there's a thought process that it's actually damaging the tissue, and so it doesn't actually help. So just do what your protocols state. You guys should know signs of shock already. For open injuries, make sure that we're thinking about our standard precautions. We typically want to start with direct pressure with all our injuries, right? Because direct pressure, all I need to do direct pressure is my hands to start with as we get our other equipment that we can use. And then we're going to do those occlusive dressings like I was talking about. You guys will see we have a number of different commercial occlusive dressings that you can use that come from different companies, right, that are specifically meant as occlusive dressings. Really, it just needs to be something that will not allow air to travel to pass through it. So when I came up through EMT school, everybody was using Vaseline gauze, which is exactly what it sounds like. It's like a 4x4 gauze smothered in Vaseline, sticks to the patient, and it won't allow air to transfer through it. The EKG little electrodes, if you guys have seen those, I worked with a lady who was from Grady Ambulance down in Atlanta. She said that was really common that they would use because they would get a lot of gang shootings with 22s, so little tiny bullet holes, and they would just put those right on top because they work really well to seal that off. Whatever it is that will stop that from going through, right? You have, you're up there eating some chips, you got your Lay's, whatever out there. You can cut that and you can slap it right on top and it will stop that from transferring. So occlusive dressing, I think occlusive dressing essentially from the chin to the belly button. If I have penetrating trauma anywhere there, I want to put an occlusive dressing on, okay?
That includes your arms?
Well, sorry, thorax, yeah. So shoulders and in, so chest from the belly button up to the neck, okay, or kind of up to the chin. If I have penetrating trauma up on the neck, we can get air emboli that will go into our circulatory system, so an air bubble that can come in and cause issues, so just throw it on the neck if you can as well. But I would rather be over-aggressive with my application of occlusive dressings than not aggressive enough as far as where my placement. So it's really should just be the chest cavity, so diaphragm to here is what we need to be concerned about. I go a little further just to cover my bases in case. Controlling bleeding, obviously we're going to do our basic pressure, and then we can do pressure dressings or splints. Splints, especially for internal injuries, can help to stem that bleeding, keep things in place. Do a little pressure on the injury, and then tourniquets. Have you guys done bleeding control yet? You guys have placed tourniquets on each other? No? Okay. If we have time, if I talk fast enough, maybe that's what we can do today is go over some bleeding control. It's dead simple, but it's something you need to be able to do very quickly when you need to do it.
Do you guys have like protocols on how you like handle your tourniquets and stuff, or like the way you like have them set up on you to like easy, or just different ways to put them on? Or?
No, some people will carry one in their pockets, but we just have them in one specific space in the bag, one specific place on the ambulance, so you know where to go, or on your engine, whatever it is, so you know exactly where they are, because it is a time-sensitive thing. But yeah, we're not super concerned about it. We typically teach high and tight for tourniquets, even though that's more comes from the law enforcement side, right? High and tight on a tourniquet. That way, if you need to use the arm, like that's what they teach like cops or military, you're going to learn. That way, if you're in a firefight and you need to shoot back, you still have use of your arm if the tourniquet's here as opposed to lower. And we try to teach tourniquets on the upper part of the extremity because I have two bones here, right? Whereas I have one bone here. So if I put a tourniquet on my upper arm, I can squeeze down around that one bone with no gaps in between. If I do it down here, my radius and only there's circulation that runs between those bones, I'm not compressing that because that section between the bones is non-compressible because of that. So typically teach upper extremity, high and tight's usually the best way to do it. And then you've probably been taught this too. If you have a tourniquet on that's not working well enough, slap another tourniquet on. We can do that. We like to do it proximally because we can cause some issues if we have already stopped blood circulation and then we do another tourniquet down below it. The kind of compartment syndrome issues we can open the patient up to, but I'd rather them have compartment syndrome and live than die. So if you're high and tight, do a second one. If you can, put it above it. But we can try to cover bleeding control after.
I think Wade may have mentioned it like a while back, but like when you put a tourniquet on, you cannot take that off.
No.
Once the tourniquet's on,
Yeah.
it just stays on.
Yeah, once it's on, keep it on. We put it on for a reason. That reason didn't change, right? And so we want to leave it on until they can sew them up. So abdominal wounds, what's this called right here? Starts with an E.
Oh, E.
It's going to be an evisceration. Guys, it's just right here. All you got to do is read. So that's going to be when the internal organs are outside of the body. So do you know how we're going to treat this?
Just put a clean cloth over it.
But there's specific things about that clean dressing we need to put over. Moist, sterile dressing, yeah. So the way I like to remember it is if it started dry, keep it dry. If it started wet, keep it wet. So internal organs, we don't want to dry them out. So you'll put some saline or something on that dressing and you'll cover it and then bandage around it. That is a gross picture. Yeah. So cover it. We can do an occlusive dressing around it as well. So we'll do that moist sterile gauze. We don't want it to be wet, but it needs to be moist. Then you can do an occlusive dressing around that just to help manage so that there's no air exchange in case that's something that could happen there. Impaled objects, are we going to pull those out?
No.
Absolutely not, unless it's impeding airway management or impeding CPR. So if we have somebody with a tree branch through their face and they're not breathing and we can't get a good mask seal, we'll have to pull it out, we'll have to remove it. Otherwise, there's been a lot of people who had gnarly impalements that impaled object is pinching off vasculature and keeping them from bleeding out, and it's saving their life essentially. And so we don't want to pull it out and now they have an arterial bleed that's hitting the ceiling because we made an oopsies, right? So we're going to leave impaled objects in unless it's affecting CPR or airway management. Neck injuries, like I talked about before, they can suck in air, so do an occlusive dressing on the neck injuries. We'll do manual pressure. But but we don't want to do both sides at the same time, right? Like some high school jock. I don't know if, again, that was a thing that you guys did. Maybe you younger people are smarter than I was and my friends were, but like you would like hyperventilate and your friend would like choke you out and make you pass out, right? That's just compressing the carotid, so your lack of blood flow to the brain. We don't want to do that to our patients. So yeah, teenage boys are not smart. So when we're doing it, we're just going to do some gentle pressure as much as we can to get that bleeding to stop. But don't do both sides. I mean, if you do what you got to do, right? If both sides are bleeding, then you'll do both sides. Just be gentle about it. And do we put tourniquets on the patient's neck? No, we don't. So small animal bites. Some of these can actually be pretty gnarly. One of the gnarlier injuries I was ever on was right like a couple blocks over that way. Probably is over here on the bench. I said I'm going to be faster, but it's a good story, so I'll tell the story. Yeah, we get called out to like an animal bite, right, like a dog bite. And my partner and I have been on tons of dog bites, and they're always something like little tiny, you know, like little Fifi dog did a little bite, maybe a little bit of blood, no big deal. So we're like making a joke about how that's what we're expecting to go to when we go to this call. And we get there, and the lady's inside her house. There's no dogs around. She said that her whatever dog was being attacked by like 2 loose pit bulls or Rottweilers, some big, more aggressive breed. And she went in to like save her dog, and the dog bit her. And we're looking at her. She looks fine. She's calm, cool, and collected. Everything seems good. She's like, yeah, I got bit in my arm. She's wearing a white shirt, and I don't see any bleeding or anything. Like long sleeve shirt, everything looks good. No big deal. So my partner's running the call. He's like, hey, let's visualize it. Can you cut her sleeve off so you can get a look at the arm? Expecting, you know, little, no big deal. So I'm cutting, and I get to here, and the yellow chunks of stuff start to fall out and are stuck to her shirt. And I'm like, what is that? That's really weird. And it takes until I actually visualize her tricep just hanging loose from her bone. That was just, her tricep was ripped off of her arm, essentially, just kind of avulsed and hanging there. I realized, oh, that's fat tissue. The yellow stuff that's falling out of her shirt was fat tissue. So it was one of the more visually striking images I had ever seen. So I don't know if she like went in and like put a new shirt on and there was no bleeding around it. I don't know how we don't know what happened. We realized her calm, collected state was just like massive psychological shock. She was just like, yeah. So it was gnarly. So you could get these. They could be pretty gnarly. Typically they're not, but it says small animal mouths. Human mouths also very, very disgusting. So anytime you have a bite, we need to be thinking about infection risk and all of that stuff. So they might need tetanus shots. They might need all sorts of stuff at the hospital. Generally, we should take them down so that they can be cleaned in the appropriate manner, even if it's not a life-threatening injury. We want to make sure it gets cleaned. Rabies is something we need to be concerned about. We want to stop that. Rabies is very scary. I don't know if you guys have ever seen rabid animals or seen like, I don't know if it happens, I'm assuming it happens with animals, but like humans get like an aversion to water when they get rabies. And essentially by the time you start showing signs, like you're done, they can't treat you. So something to think about as well. If we are concerned that there's a rabid animal, I think if you're bit, you can get treated immediately. It's just once you start showing signs, it's done its course. Human mouths, like we said, are gross. You will go on human bites, so keep that in mind. We want to make sure that that's managed as well. Go to the hospital, tell them it's going to be okay. So burns, we're going to see burns, not a ton of burns, but you will see burns out there ranging from minor burns all the way up to possibly like really, really major burns. They can be really life-threatening, especially if we start to have facial burns or airway burns. We need to be really aware of that. Like inhalation burns are really, really scary for us. And they are typically the most painful injuries patients can go through. So if possible, you have a burn patient, try to get a paramedic en route because we can give them all of the drugs to try to make them hopefully feel a little bit better. There's a couple different sources and we'll talk about them. Make sure that we're doing a complete assessment and little kids and older patients are more susceptible to major injuries from burns because of what reasons? What reasons do you guys think? Their skin's thinner, that's a big one. And for children especially, their body surface mass is much higher than it is for an adult. So just based on how their bodies are, especially their gigantic craniums. If you guys have not noticed yet, the kids have huge heads. Now you're going to look at kids and be like, whoa, like little bobbleheads, right? And so they have a higher surface area to the body mass, and so they're also more prone to issues with burns. We can have all sorts of different transfers that are going to cause burns. Thermal burns are going to be when the skin gets to 111 degrees or higher. And I'm sure you guys have all had some sort of at least minor thermal burn before. They suck, they're uncomfortable, but typically they're not going to be life-threatening, hopefully. Couple different things that affects, it's loud, affects the severity of a burn. The temperature, obviously, something that's 150 degrees is not going to be as bad as something that's 500 degrees, right? If we're touching it. The concentration, so how direct that was, and the amount of time, the duration of the exposure is also going to make a big factor as far as how severe and bad that burn is. The greater the heat energy, the deeper the wound possibly, so that's something to think about as far as like how bad that burn actually is. And reflexively, we are going to try to limit that. Do you guys remember reflex arcs? Did you guys talk about that? In the spinal column, we have reflex arcs. So just reflexively, you guys maybe have done it before, like you touch something that's hot and your hand's away before you register that you touch something that's hot. Normally we have our nerve pathways that go two ways, right? We have sensory nerves that say this is happening, that go up to our brain, and our motor nerves that go from our brain to our hands or whatever, right? We have a reflex loop in our spinal column that will recognize those injuries, and it won't go to the brain. It will just go, that reflex loop will flip the switch essentially, and we'll move our hand away or whatever to stop ourselves from getting injured. So reflexively we're going to do it, but you know, it doesn't mean it's always going to happen. Probably the worst burn I was on was a guy that had a seizure. He apparently liked really hot baths, and so they had his water heater turned up really high, and so he would run a really hot bath, and then I would assume let it get cool down enough that he could safely get into it. But so he was running the bath to get a hot bath going, and he had a seizure history, and he had we don't know, we assume he had a seizure as he was over the bathtub, as the bath was starting to fill up. And so family member found him like in the bathtub. So he had like here down severe burns, both sides, and then kind of splashes all over his body. But he was not able to protect himself. Normally, you touch that hot water and your hands go away, and maybe you'll get a little tiny burn, but it's nothing big. He had his hands submerged for a while. Maybe the gnarliest call I was ever on in the aspect that he was you guys maybe don't know the term postictal state yet because you haven't done medical, but after you have a seizure, your brain resets essentially. And so people are usually really confused for half an hour, depending on how long it takes. People are different, but they're usually really confused for a while. So this guy was really postictal, really confused, not sure what was going on. His skin was just like sloughing off from like the scald burn, right? And so as it was like sloughing off, he like looked out and started like trying to chew it off. That was gross. That was a gnarly one. So, you know, you might have that sloughing of the skin, especially with like steam or like water type burns. But just if they can't manage it, then they can't manage it. So keep that in mind. So yeah.
So when it comes to that, and they're just like kind of out of it and like the dangerous and stuff, but they're at burn, how would you restrain them?
The best you can without hurting them. We did some chemical restraint that you guys don't have the ability to do. I gave him a lot of medication.
Okay.
I gave him a lot of drugs to, for one, he was like screaming and in a lot of pain. So we just gave him a ton of drugs. You guys will just do the best you can and try to get ALS en route. Yeah. Because you don't want him to further injure himself, but he's going to fight you a little bit in that case, those patients. So yeah, there's not a good answer for that. Just do what you can to keep him safe. Yeah, I think that's the only time. So fentanyl, morphine, those medications that we give can bring blood pressures down. So typically we will always check a blood pressure before we do medication administration. I think that was the one time in my career I did not check a blood pressure first because his arms were all burned. And I was like, you need like you're sitting up and talking. I know your blood pressure is good. You need this right now. So we dumped a lot of drugs into him. So we talked about the skin and what the skin does for the body, right? Infection control, heat, all that stuff. When we have a bad burn, that is going to destroy that barrier. And so all of those good things that the skin does, it's no longer intact to do those things. So that's what we need to be thinking about. And when we're talking about burns, the biggest concern for us is burns to the airway, right? So what happens to tissue when it burns? It swells. What happens to our airway when our airway burns? It swells, and it can swell closed. So that's something we really need to be concerned about, burns to the airway. So if you have a patient with soot around their mouth, if they open their mouth and they look like they're burned inside, or you see black spots, maybe their nasal hairs look singed, those kind of things. Maybe they're good right now, but that's a really extreme load and go patient, because they could start to swell very quickly and they need to be managed. So that's when either you're going real fast to the hospital, or you're getting a paramedic real fast to you so that we can intubate them, those patients. Circumferential burns, especially to the chest, can be really concerning because I need to open my chest to take a breath. If I have a circumferential burn all the way around my chest wall, it's going to affect that. So that can compromise breathing. And then even to an extremity, it can cause pretty massive damage. So if you guys were to look at St. Al's trauma protocols, it will say any circumferential burn is going to be a priority trauma that needs to go to the hospital and go to the burn center. Burn severity depends on the stuff we already talked about. Other medical conditions can have an effect, especially for healing down the line. Diabetic patients don't heal very well to skin stuff, so just something to think about. And like we already talked about earlier, those areas that have thinner skin are also more prone to issues. So face, hands, feet, genitalia, that kind of stuff can be more severe if we have burns in those areas. I feel like the terminology they use as far as describing burns goes back and forth between superficial or degrees. So you guys will hear it both ways. Superficial is just going to be that top layer of skin. It's going to be really painful. Usually not going to blister, but that's probably what you guys have all had in your past from whatever reason before. So partial thickness is going to go down usually a little bit into the dermis as well as the epidermis. And we might see some blistering there, and those are going to be incredibly painful. And then there's full thickness burns that are going to go through all of the layers. Usually those are painful, but usually it's kind of like first and second degree leading into third degree. Third degree burns, usually that section is not painful because all those nerves are completely burned away, but all the stuff around it is going to be extremely painful. So you might see that, and then you might also hear people talk about fourth degree burns. That's when that flesh is pretty much burned completely away. You can maybe see like bone or something like that when it's burned that deeply. You might hear fourth degree burns. So those are kind of pictures of the three different. So just like a, pretty basic sun exposure, little sunburn. So like a first degree. And then you'll see this one has those blisters. So that's going to be like a second degree. And then that's a full thickness burn. That guy is in for a lot of years of recovery, and it's going to be really rough. So we can use the rule of nines for finding burn surface area. And some of your protocols might be dependent on BSA or burn surface area as far as your transport decision and what we're going to do. And you are highly likely to have to calculate rule of nines for your national registry test or maybe some of the benchmarks in here. So make sure you guys know your rule of nines. It'll be on one of the slides coming up. Another thing we can do is use the rule of palms. You guys good? Yeah. So there's the rule of palm as well. And so using the patient's palm, not your palm, because obviously if I had a baby, my palm would cover a lot more than their palm would. But a person's palm is typically about 1% of their surface area. So if you can look at the patient's palm and see a burn and see that it's about the size of two of their palms together, then they're about 2% burn surface area, right? Does that make sense to you guys? So that's one way we can do it. And then also the rule of nines. And then this is only going to work for, it's going to work for partial and full thickness burns. So not those superficial burns. We're not worried about those. This is for partial and full thickness. So this is a rule of nines. Make sure you guys take the time to get this down, okay? It's going to be different depending on the size. So babies are going to have big old gigantic heads, and so their heads are going to be twice the value of adults. And then kind of in between, like preschool age, maybe it's going to be a little bit different. But make sure you guys are learning this. And sometimes it'll be broken down, like the chest would be 9, the abdomen would be 9, and the whole torso would be 18%. Okay, so if we're looking at this and we have a patient who has, their whole right leg is burned, that's going to be 18% burn surface area. Both legs burned would be 36% burn surface area, right? So that's what we're going to do, and they're going to want you to try to calculate burn surface area as much as you can. Can we be super accurate with it? Probably not, but we need to try our best to do that. And if you add it all up, it ends up being 100%. So when looking at a burn, we need to try to find the source, the depth, and the severity. So depth is going to be based off what degree it looks like, and severity would kind of follow that as well. And source of the burn is going to be good, so we can pass that along to the hospital so they know what they're dealing with. You guys might have heard this. Wade has maybe talked about this before, but we hold a very special place in this chain of healthcare, and that we are the only people that see the scene, right? A hospital doesn't see the scene. The nurse is there. Nobody else is going to get to see what that scene looks like. So there's some clues maybe that we're the only ones that can get, right? So make sure you're taking the time when you're on scene to look, see what happened, get that good story from the scene so we can pass that along. Because if not, that story might be lost forever as far as their healthcare chain goes, okay? Obviously, if there's burns, we need to be concerned about ourselves not getting burned, so look at that. We'll go through this really quick because this is more or less the same stuff. Look for clues that may indicate abuse, especially for children with burns, right? If they have lots of little circular burns all over themselves, what are you thinking? Cigarette burns, like a line, maybe especially like kind of on the backside, maybe like a curling iron, right? This unfortunately is something that happens we need to be aware of. So look for those signs, look at how the kid reacts to the parent or the caregiver when we're on scene. I already talked a little bit about facial burns. Make sure that you're looking for that specifically for the ABCs. If they have a bad cough or a large amount of coughing, or they complain of like some itchiness or something to their throat, or they're burning in their throat, that also might be a sign of a respiratory burn, so keep that in mind. Transport decision, make sure that you're aware of what your protocols are. We don't have a burn center in Idaho. The closest burn center, I believe, is Salt Lake. But we'll still take them to the local trauma center, and then they'll get flown from there to the burn center. So I think that's the one major thing that we don't have in the Treasure Valley is going to be a burn center. Yeah, so just keep that in mind. Just know your protocols. And then ALS for you guys is a really good thing to get because burns, we might need to intubate and do some airway procedure you guys can't do. Or just for patient comfort, lots of drugs, like lots of medications. Drug them up, man. They earned it at that point if they have severe burns. Looking at burns, it's all pretty straightforward stuff. Some stuff you might want to ask about. Difficulty breathing or swallowing, again, just to make sure that they don't have any of those airway burns. Do your physical exam, look them over, try to get the rule of one, or the rule of palms, or the rule of nines. Do the best you can to look for that classification of the burn, and then take them to the correct hospital. Looking at doing an end-tidal CO2 is not a bad idea, or also looking at the carbon monoxide levels. You guys may or may not have the ability to look at carbon monoxide levels. If you're on the fire side, you should for sure have the ability to check a patient's carbon monoxide. So not a bad idea to throw that on as well, just to see where that's at, especially if they've been in a burned area for extended period of time. They may need some extra oxygen. So the number one thing that we can do, like I said before, is just stop that burning process, right? So whatever we can do to do that, we're going to do so. So thermal burns are going to be caused by heat. Could be scald burns like we talked about, or flames. You know, the frat boys with the fire that are drunk that fall into the fire, those kind of things. It happens. You guys will go on those kind of things. Steam burns can be pretty gnarly because the skin just gets really moist and kind of, like I was telling you, kind of like slough off, just kind of slides away from itself. So keep in mind when you're looking at that could happen. Flash burns are typically going to be explosions, but can also be lightning strikes as well. I think there's a picture of a lightning burn in here that is pretty gnarly. Or maybe it's just an electrical burn, but either way, it's pretty gnarly. So stop the burning source and cool the burned area if possible, right? So small burns, we can irrigate or something, cool it down. And then we want to remove all the jewelry, especially around the burned area, because burns swell. And if we have a bracelet and we have on, right, especially a tighter bracelet, and we have a burn in that area, it's going to swell into that bracelet, and it can cause major issues. So take it off when you can. If not, you should have a ring cutter on your ambulance engine and your bags, whatever, that you can cut rings off. And if you have like a bracelet, if it's something like, you know, if you have like one of the guys with like the tungsten rings, that's going to be a challenge, but like gold is pretty soft, gold, silver, those are pretty easy to cut off if you have to. And we're going to do a dry dressing to these patients, okay? We're going to do a dry, sterile dressing. We carry typically what's called burn sheets that are specific for this. You'll just put those over those patients. We need to keep them warm. That barrier between the outside environment, right? Like right now, this room's probably 70 degrees, somewhere around there. What's my internal temperature? 98.6, 37 Celsius, something like that. So the atmosphere, the environment is much colder than my internal temperature. If I don't have that barrier to protect me from that, that's going to affect me internally. So we need to make sure that we're doing like a nice dressing to keep them warm. Inhalation burns are exactly what you would think. We're going to go a little bit quicker through this. Make sure you think about ALS on inhalation burns. If there is a group of people with headaches, nausea at the same time, we need to be thinking about carbon monoxide, right? What is our SpO2 monitor going to show on a patient with carbon monoxide poisoning? Lower than 60? Do we have anybody that agree, or who agrees lower than 60? We're going to have low SpO2 on a carbon monoxide patient.
She did.
Oh yeah? Yeah. Okay, who disagrees? Why?
Because it's going to present the same as oxygen because of the amount of molecules.
Yeah, exactly. So SpO2 doesn't measure oxygen saturation. That's what we call it. That's not what it measures. It measures hemoglobin saturation. And carbon monoxide attaches to the hemoglobin. Hemoglobin likes carbon monoxide a lot more than it likes oxygen. So a patient with carbon monoxide poisoning is going to have a good SpO2. We can't use that as a judge. But if we have, especially a group of people with headache and nausea, that can lead us to think maybe it's carbon monoxide, and we can put on a carbon monoxide specific monitor. So chemical burns can happen from all sorts of different things. Usually going to be strong acids or strong bases, strong alkalis. Eyes are particularly vulnerable. So hopefully if you go somewhere that this is the case, they have an eye wash station that people can go use. Was that the office, right? I think it was Andy needed to like do the eye wash station. It was like really scary, like the video, right? Those are real things. You'll see those in industrial settings. They're just like fountains that you put your eyes over that will wash them out. So that's something we can do if we're on scene and the eyes have some sort of burn or chemical in them. You guys can go use that before you leave to clean those eyes out. Another thing we can do, you guys might have seen this, you can do a nasal cannula and put it over the bridge of the nose, and you can attach that to some saline and you can flow it in and it will drip out of the bridge of the nose to wash the eyes. That's a good way to wash the eyes as well. I had to do that for a guy over, a military guy over the airport because he got jet fuel in his eyes. So he did not look very comfortable. Make sure you guys are thinking about what's going on and what you're doing. And if there's a chemical, we need to be protecting ourselves against the chemical. So make sure you guys have the right PPE for those chemicals. We want to remove whatever is burning them from the patient. If it's a dry kind of a thing, we want to brush it off before we irrigate them, because we don't want to, make chemical soup by just making a lot of that wet. So we'll brush it off the patient, and then we will flush with water. Make sure that you are trying to figure out what that chemical is, because some chemicals are activated by water. So we don't want to just start, dousing patients that we don't know what the chemical is. You should carry an ERG guidebook in your apparatus. So that's going to be the emergency response guidebook. That's the orange book. You guys might have seen it. If not, you will see it when you do your hazmat class that you have to do for this class. But it will tell you different chemicals, and if they react to water, you can look up the chemical in that guidebook. And then if you go to like an industrial thing, they'll have the MSDS, which are the Material Safety Data Sheets, I think is what MSDS stands for. You guys have probably seen those before. They're a big, thick book that sits somewhere on site. That's going to have information about all the different chemicals, and you can look at those as well. So look at that before you start. Make sure that we decontaminate a patient before we put him in the ambulance, or else you're going to be at the hospital stripped naked out in the bay as they hose you off as well. It has happened before. It will happen again. And don't bring them into the hospital with a bunch of dry chemicals on them. They're going to be real mad at you, because then they have to do a lot of stuff at the hospital to decontaminate everything. So try to decon outside. Let's see. Yeah, do it for a while, the flushing. Flush and flush and flush and flush, and then keep flushing. 15 to 20 minutes to flushing. Electrical burns. So electrical burns, we're concerned about the burn, right? But what are we also concerned about with a patient who has been in the situation that had enough electricity to burn them?
Like internal damage?
Yeah, more specifically, what are we really concerned about? One thing specifically. Their heart, right? Because our heart uses electricity to beat correctly. So if there's a big electrical override of that because somebody gets zapped, it can cause some major heart issues, some major cardiac issues. So we really need to be thinking about that anytime we are on some sort of electrical injury. Our body, thankfully, is a great conductor. So we like to have stuff go right through us. Make sure you're thinking about your safety, right? We don't want to go try to pull somebody out that's on power lines and then get zapped ourselves. So think about that when we go into that situation. Typically for electrical burns, you're going to have where it enters and where it exits, right? So you'll probably have maybe a foot or something where it exits out into the ground, and then wherever they touched. Just make sure you're looking for 2 different injuries, 2 different burns when you have an electrical burn patient. So this is the electrical burn. That looks to me like maybe the bottom of a foot. Yeah. So probably, they're grounded out here, they touch something and it goes through them. And so that's kind of the exit wounds. There are some pretty cool, if you guys have ever seen lightning scars from people that have been struck by lightning, it looks like tree branches in the back. Those look pretty cool. I mean, I don't want to get one, right? But if I did, it would look pretty sweet. Yeah. So make sure that we're thinking about the cardiac issue. These patients tend to do really well with early defibrillation, right? Because they have a healthy heart that was functioning totally normally until that electrical injury to it. And so if we can shock them, get them back to where they need to be, typically they respond really well to that. And then treat them as you would pretty much everybody else. Tasers, you guys will see tasers out there. Depending on what your protocols are, you might have to pull taser probes and stuff out. I've done that plenty of times. We have to pull those out. It's pretty. The ones that we carry would literally just like a Harbor Freight pliers that we would pull them out, and then we put some, antiseptic and stuff on it. You guys might have to do that. Just remember that that's electricity, and so there is the possibility of cardiac dysrhythmias and cardiac arrest when people get lit up with one of those things, okay? So just keep that in mind. Radiation burns, we're not really going to go down this. This can happen. There's a couple different, well, you guys might need to know the different types of radiation. Alpha being no big deal, gamma rays being the worst. Yeah, know that. Outside of that, realistically, you're probably not going to have to worry too much about radiation burns. Make sure you're safe. Treat them like you would anything else. So there's a bunch of different types of bandages. Splinting can help. We're going to go through this really quick. Use them to control bleeding. You're going to have a bunch of different sterile dressings. They're sterile until we open the packaging, and then they're no longer sterile, but we will still try to keep them as sterile as we can before we put them on the patient. You'll typically have a bunch of like 4x4s is what we call them, because they're 4 inches by 4 inches. You guys will see we have a bunch of those here, and then all different types of sizes. You'll have tape to hold them down. You might have something called Coban. You guys have all seen Coban. It's like that kind of self-adhesive, stretchy bandaging. We can use that to wrap up and cover those as well. This stuff is all really straightforward. We don't need to talk about bandaging for you guys, right? Pretty easy. Bandages are pretty straight, pretty easy. Okay, cool.